Good morning, this is Dr. Joe Moscato, and this morning we're going to talk about ovarian carcinoma. Of the gynecologic malignancies, this is the one, unfortunately, which kills more women than any other. And it's very hard to diagnose initially, and treatment is a challenge. Now, there are a variety of risk factors for ovarian carcinoma. Things that increase risk are infertility, BRCA 1 and 2 very strongly. There's some increase with hereditary non-polyposis colon cancer, the syndrome, the Lynch syndrome, and possibly from endometriosis. However, things that decrease risk are a use of oral contraceptives in the past, multiparity, tubal ligation, interestingly, breastfeeding, and the use of progesterone. Now, ovarian carcinoma is an epithelial, and what we're talking about is epithelial ovarian carcinoma, which is the usual and common cancer and the subject of this talk. There are very rare other kinds, such as germ cell carcinomas of the ovary, which are actually treated with regimens very similar to testicular carcinoma, and other rare forms, such as sex cord tumors, stromal cancers, such as granulosa cell thecoma, and Sertoli Leydig cell cancers. And we're really not going to talk about those today. The vast majority of what you see on 2100 are epithelial ovarian carcinomas. Now, the early symptoms are slight. It has a reputation as a silent killer, although 95% of patients with ovarian carcinoma have some ill-defined symptoms. And this has become a push from the American Cancer Society to try to make this diagnosis earlier. However, the most common symptoms are bloating, pelvic fullness, urinary symptoms, or dyspareunia, so you can see that these are fairly non-specific symptoms. And they don't always prompt a pelvic examination, although we're trying to push that these actually should. The diagnosis can be difficult. A pelvic examination is not always sensitive to early stage disease. A CA-125 is elevated in 80%, but unfortunately there are a lot of false positives, many more than there are true positives in the general population, and so that makes it a very difficult screening test. And in some series, several hundred women will have to go undergo surgery for every one cancer that's found if you simply screened with a CA-125. You may have heard some news of a proteomics assay that's now being proposed, but I think it's still too early for that, and most experts say that even though this is commercially available, that it really should not be used, since the false positivity rate is still too high. Transvaginal ultrasound is a common method of diagnosis. A CT scan can be used for suspicious findings, but unfortunately a CT scan is fairly non-specific and non-sensitive and insensitive for this disease, with small tumors difficult to diagnose, and especially metastatic disease. Large tumor masses, of course, can be seen. Most ovarian carcinomas are discovered at a late stage, and only 5% of patients have stage 1 disease. Now, the estimated 5-year survival is very much related to residual tumor volume after surgery, and here is a slide which adjusts this for age and international FIGO staging. But one can see, even with all of that, that the survival is clearly better at 5 years if you have what's called an optimal resection versus a suboptimal resection. So less than 1 centimeter versus greater than 1 centimeter is the smallest tumor remaining in the abdomen. This is the smallest individual tumor. There can be multiple lesions of that size. Now, surgery is a cornerstone of this disease, and what wants is a maximum cytoreductive surgery. This is the one cancer, besides brain tumors, where resection of bulk disease is important, even if one cannot eliminate all cancer. Optimal debulking, as we said, describes a residual of no tumor greater than 1 centimeter remaining. And surgery may be the initial therapy or may be done after several cycles of chemotherapy, and we call this interval debulking. And studies have shown improved outcome when surgery is done by a gynecologic oncologist due to the potential thoroughness of the surgery compared to other gynecologists, for example, or general surgery. Chemotherapy is indicated for all stages of ovarian carcinoma except stage 1A and B that are grades 1 or 2. So once you reach stage 1, even grade 3, even if it's resected, chemotherapy is recommended. There's also another entity called ovarian carcinoma of low malignant potential, which is a histologic description of a certain kind of ovarian carcinoma, usually in younger women, which has a very slow growth pattern. And unfortunately, it can recur, but chemotherapy is not extraordinarily useful either. In terms of chemotherapy, the first-line chemotherapy is, in current-day standards, Taxol and carboplatin for 6 cycles. However, recent data have shown an improvement in survival with intraperitoneal cisplatin and intraperitoneal and IV Taxol. So we'll see this being used. This requires an intraperitoneal catheter and infusion into the abdomen. It's certainly a more difficult undertaking for both the patient and the staff, but for those patients who are young, who have no other contraindications, this is what's done. Second-line chemotherapy can include any of those things noted, like topotecan, Doxil, gemcitabine, and the others. However, one goes back to a platinum agent if more than a year has gone by since any exposure to platinum, or even sometimes 6 months, but certainly for more than a year interval, and one will often see further responses. Investigational agents include Avastin, which is very promising. It's been hampered by early reports of bowel perforation, but in earlier stage disease, this appears to be less of a problem and can very dramatically improve ascites. It is still investigational, as noted. High-dose chemotherapy has been tested and is not effective in terms of overall cure rates, and some other agents have been used, like hormonal agents such as tamoxifen and Arimidex, which may be palliative with low toxicity, and so they can be useful. Palliation of symptoms is very important. Bowel obstruction is very common and usually marked by dysperistalsis, and you'll see this frequently on 2100. The need for a PEG tube can be determined by the benefit of it from an NG, so you'll see us try that. Ascites is generally treated with paracentesis, and one can use an indwelling peritoneal catheter. And pleural effusions can be treated with sclerosis or Pleurex catheter. Pain control is important, but usually less of a problem than the bowel symptoms. And don't forget, hospice is very important. Some of these patients are young and the desire to live is high. However, the prognosis for recurrent disease is grim. Paracentesis and thoracentesis can be a problem for hospices, but we're fortunate in Columbia that they'll allow this. Pleurex bottles are expensive, but nevertheless, palliation is important, and hospice is very important. So I appreciate your attention this morning. Thank you for this, and if you have any questions, as always, don't hesitate to let us know, and we can answer anything else. Thank you.